Marrisa. I'm our Director of Community Nursing for the Health and Wellness Department at our agency. So I oversee all things that are medical. So I've been asked to kind of try to help bring some awareness of some things to look for when we're working in our interim housing locations and also just with our clients in general. So I created this training called What to Look For. And like I said previously, before we started the recording, please ask questions. It is the best way for all of us to learn and look at situations that we've all experienced or potentially could experience. So I'm going to just talk basically as to provide basic knowledge on medical conditions, right? Because no one in here is a medical provider. We don't expect people to be medical providers or have medical education, but we want people to be able to identify some things that may be witnessed in our facilities or out in the field. And if there's a medical staff present, then you're going to consult with them. And then when in doubt, notify your supervisor or call 911. That's always going to be the thing. When in doubt, supervisor 911. Okay. If your supervisor is not available, call 911. If you're in doubt and it's an emergency situation, you're going to call 911. Okay. So the first two things we're going to talk about is hypertension. And again, this is just a general overview of some things to look for or some things to listen for when you're talking to your clients. So we know that a lot of our clients have chronic medical conditions. Hypertension is one of the most common, which is high blood pressure. And if somebody is experiencing symptoms of high blood pressure, right, without having the ability to check what their blood pressure is, because again, we're not all medical providers, is if somebody's saying, I have a really bad headache today, and my vision's kind of off. Then the next question that you want to ask if you're sitting with a client and they say that is, do you have high blood pressure? Have you taken your medication today? That's kind of some of those when we're talking about like looking at questions to ask when a client says something, right? So my vision's kind of off. Oh, do you wear glasses? Right? So it could be something else, but are you experiencing any dizziness? No, but I have a headache. So that's some signs of hypertension. When hypertension and someone's blood pressure is really, really, really high, they can experience a stroke. So this is kind of what a stroke looks like on someone. And I will tell you that I have done this training multiple times for our interim housing staff. And we had a client support specialist who was this was something that she really became a specialist in, was recognizing a stroke. And a lot of strokes happen where they're micro, meaning they're like smaller strokes, and go unrecognized because they're not like a big massive stroke where someone's falling down and you're finding them, non-responsive on the ground or unable to move. These are much smaller than that. So it's one-sided body weakness. So you may notice that a client is like walking with a little bit of a limp when you've never seen that before. Hey, I noticed you're walking with a limp. Did something happen? Or they've got a little bit of a slurred speech. So I had one client who had come, this when I was working at a clinic, and she had come to us and she said, I'm so upset. My whole family thinks that I'm drinking again. And it was someone who had a long history of alcohol use, and she had stopped drinking and had not been drinking, and she had a slur that started. And she's like, my family keeps pointing out that I have this slur, and it started like 2 weeks ago, and I'm not drinking, and I don't understand. And we looked at her, and we asked her to smile, and she had the uneven smile, right? There's another thing you can ask them to put their hands up. And what we realized is that she had had a small stroke and her family was blaming her. I think they'd even kicked her out of the house because they thought that she was using. So, and this is something that you can ask someone to smile. If you notice that someone's slurring, that they haven't been slurring before, if you ask them to smile, hey, can you smile for me? One side will go up and one side will stay down. And if you see that, then that's something that you want to reach out to a medical provider for, get them to a hospital for evaluation. Okay, any questions on that? So these are the warning signs of a stroke. So Someone's balance is off, their eyes, blurred vision, their face we just talked about, it's a little asymmetrical with some drooping on one side. Their arms or leg, one side may have weakness. So again, if you notice that somebody's limping that hasn't been limping before, they could have sprained their ankle. Sure, no problem. But is there any problem with saying, hey, again, I noticed that it looks like you're limping. What's going on? And they go, oh, I twisted my ankle. Okay. Do you need any medical attention for that? No, you're good. Okay. Or they go, I don't know, but I've been kind of tripping over my foot this last week. And you say, can you smile for me? Right? So speech, the difficulty speaking. So a little bit of a slur there. If you notice any of those things, we should get them to the hospital and have them evaluated. And so whether that's transporting them or calling 911. Okay, the next main medical condition that we see a lot of. So diabetes. Can someone read for me under hyperglycemia? Hyperglycemia means high blood sugar.
I'll go ahead. Extreme thirst, frequent urination, and long-term effects are problematic.
Right. So the key for hyperglycemia, hot and dry, sugar high. So when you are hot and your body is dry, what do you want?
Water.
Water. That's right. Thirst, like you can't get enough water. Right? You just can't get enough. No matter what you do, you're drinking. So that is a really good indication that someone's sugar is high if they're diabetic. And they're also going to the bathroom a lot. Whether they're drinking a lot or not, they're going to the bathroom a lot. So if we look at the pictures over here, here's some of the other symptoms that you can get when you have hyperglycemia. Extreme thirst, we talked about, the need to urinate often. Skin gets really dry. People get really hungry. You can get blurry vision with this, drowsiness, wounds don't heal. So question, hyperglycemia, short term, someone's sugar goes high, right? Say it's in the 400s. How dangerous is that in the immediate moment? Does anybody know?
Very dangerous.
Do you know why?
Because they can go into shock.
So with hyperglycemia, the long-term effects of having high sugar, it's long-term effects of having a high sugar. It affects your vision, so people can go blind. It affects your kidneys, and your kidney functions can slow down and actually stop. So over time, when your sugar is high, it can be really, really dangerous. They can also go into something, again, this is a little bit more advanced, something called diabetic ketoacidosis, which means their sugar's really high. You guys have all heard the word keto probably before, but it puts you into ketoacidosis. That can be really dangerous and requires hospitalization. The really, really concerning immediate, when someone is hypoglycemic, meaning they're low, this is the one that if somebody is hypoglycemic in this short-term immediate can be deadly. So can someone read me the hypoglycemia one?
Yeah, I can read it. Cold and clammy, have some candy. Sugar is low. Cold, clammy to the touch, sweating, confused. If conscious, give juice, regular soda, or candy. If unconscious, call 911.
Right. Has anyone seen anybody who's hypoglycemic, whose sugar goes low?
I did.
Yeah, we had.
I was doing EMT, a ride along, and we got called out. There was this man at a 7-Eleven, and I guess he just started going hysterical, started throwing stuff. So they called the police in and they put us on standby. But, he tried to communicate, but the police finally went in and approached him, and it was because his sugar had dropped, and all he wanted was a drink or something to bring up that sugar.
So he was confused, but it sounds like he had a little bit to know he needed to get into that 7-Eleven and probably like get towards something like the soda machine or the Slurpee machine so he could get that sugar in his body. And so when we talk about knowing that someone's, so did you have something to say before I keep going? Sorry, I know you started to talk.
Oh, I was just gonna say that as an example. Earlier today, we had a case manager dropping off a client, and we were standing outside in the heat, and she was like, "Sorry, I have to take a break. I have hypoglycemia, and I need to eat something." So she put out a snack. She's like, "You guys don't want me to pass out right here while we're doing this." So that was just my little example.
Yeah, that's a great example. And there's people that may not have diabetes that do have hypoglycemia, where your sugar just drops. For people like that, you have to keep a snack with you at all times. I always keep something in the car. Always, always, always. There was a nurse that I worked with. She always kept something in her scrub pocket because we didn't get really good breaks when we were nursing inpatient. And you would see her, all of a sudden she'd be standing at the bedside with a client and she'd be reaching into her pocket eating, and she wouldn't even realize that she was like eating at the bedside with a patient because she had gone hypoglycemic, and she would get a little confused. But these are the symptoms of it: shaking, fast heartbeat. People, usually they're sweaty, right? So, you know, when you get a fever, you get sweaty and clammy. So this isn't a fever part of it, but this is that clammy to the touch, like cold, sweating, sticky, dizzy, anxious, hungry, confused, irritable. People don't act like themselves. So I think this is like, if somebody is conscious, and you can say, you can tell when someone is in this state. It's not just that they're in a state of confusion. They do also have these like clammy, sweaty look to them where they lose their color. And if you know that they're diabetic, because we usually know our clients which ones are diabetic, you can say, "Hey, have you checked your sugar? Do you know what your sugar is? Do you have your glucometer, or if you don't remember that it's called a glucometer, do you have your machine to check your blood sugar?" And if they don't, and they're feeling like that, this is the thing. I'd rather them get a little bit of sugar in their body and their blood sugar go up than have them not have anything and their sugar go down, because you can become unconscious when you're hypoglycemic, and you can go into a coma. So I put on here, if conscious, give juice, regular soda, or candy. I have been at our facility at times like this where someone's in and I'm like, "Go grab a soda for me," and someone came back with a diet soda. Would a diet soda work?
No, because it doesn't have sugar, right?
Correct. So, and if you don't have juice or you can't find candy, usually we have sugar at our facilities because it goes with coffee in the morning. You take some sugar packs and you mix it with water. Whatever you can to get somebody a little bit of sugar if they're like this. It takes about 15 or so minutes for the sugar to get into their bloodstream and really like start to affect them and them start to feel better. So this is one of those things. And again, the very, very beginning thing that I said, which was what? You guys remember at the very beginning of the training? I'll keep saying this through the whole thing. But when in doubt, what are you going to do?
Call 911.
Yeah, call 911. So if you're in this case and you're like, "Okay, we just gave him a little bit of sugar, but he's like, still seems a little bit off and he's sweating," and just call 911. Okay? But this is a small intervention that you can do to help in that moment if you realize. And especially if they're not confused enough and they can check their sugar, they'll know when they check their sugar, "Oh, it's really low, I need some sugar. Can you get some for me?" We had a client at one of our facilities. He routinely would go hypoglycemic and I would find him non-responsive in his bed. I do not expect any of you to be doing anything if you find someone that's non-responsive or barely responsive other than calling 911, right? I'm trained differently than that. I did different interventions with him than what you guys would do. You would be calling 911. What happens if you find someone who's barely conscious?
Call 911.
Right. You're going to check them first. Are they breathing? Do they have a pulse? and you want to call 911 and give them all the information that you can. You want someone to stay with them. We're going to get there. Okay. Overdose. Has anyone had the Narcan training or the overdose training yet? Okay. So this is just going to be a brief overview of that because you guys have had it. Leslie, you want to read some of these for me? Or all of these for me?
Sure. So decreased level of consciousness, pinpoint pupils. This relates to use and not just overdose. Heart rate and breathing slow down and sometimes to a stop. Blue lips and nails are caused by insufficient oxygen in the blood. Seizures and muscle spasms. A person experiencing an opioid overdose usually will not wake up even if their name is called or if they are shaken vigorously. If arousable, they have been known to be agitated, argumentative, defensive, and some use hostile, abusive language. That's a symptom to look for. And then the death rattle, which sounds produced by someone who is near death.
Okay, and what were you guys taught if you find someone who's in an overdose?
To grab the Narcan, check for, if they're okay, and then just insert it to their nose.
How do we check if they're okay?
Isn't it the chest rub thing too?
Mm-hmm.
Right. So we do the chest rub. So you can do a sternum rub. You can do a pinch right here. There's one, it sounds really inhumane. You rub a pen on the bed of their finger. These all create what's called pain stimuli. If someone is in an overdose, they will not react to pain stimuli. If someone is unconscious, they will not react to pain stimuli. Can you give Narcan to someone if you think it's an overdose and then find out it's not? Will it harm them?
No, it won't.
No, it won't. So if we find somebody down and we think it's an overdose, we're going to grab that Narcan. And then while someone's grabbing the Narcan, you guys remember, you find someone who's down, you're going to shout out to another staff member. If there's not another staff member around, you're going to shout out to anybody who can help you. Hey, get this for me, right? Really directive, not just somebody help. You call 911 for me, right? If you have a chance to call 911 from a landline, it's better because when you call from a cell phone, it doesn't get routed. It usually goes to highway patrol first. You are calling from your cell phone, you need to say, I need police and what area you're in. So they can, or I need paramedics, this is where my address is. Okay, so it's very clear, precise when you're calling and have as much detail as you can in that moment. And this is, you wanna look, listen, and feel, okay, right? So we're looking at them, we're listening, and we're feeling. The death rattle, I wanna talk a little bit about, because I don't think they talk about that in our Narcan training. Has anyone heard about the death rattle before? Okay, can somebody tell me what you know about it?
It usually happens right before a person expires.
Yeah, exactly. It is a deep snoring rattle sound, not snoring like, oh, we're in bed and someone's in a deep sleep and they're snoring. There's a rattle that comes with the snore. Again, I just use scenario after scenario that we've walked through at our agency. There was a client who came to one of our support staff and said, person in the bed next to me, she's snoring and it's not like her normal snore. And at that time, no one was, if you're not medically trained on what the death rattle is, it's not something that you would ever think differently about. That client was actually found deceased not that long after because she was experiencing the death rattle at the time. So it's really important for me that we really educate, especially our overnight staff who are doing checks on clients in our interim housing, on what to listen for. Because even though they're going around, they're checking clients, we want to talk about what we're listening for also, that we're using all of our senses. Okay, who wants to read head trauma for me?
Head trauma, check level of consciousness. Ask the client, what is your name? Where are you? What day or month is it? Who is the president? If decreased, call 911. Should I say deceased or decreased?
Decrease.
If alert, okay. If alert to name, location, date, and situation, monitor. If intoxicated, send to ER, call 911. Decreased pupil reaction or pupils not equal, send to ER. If bleeding, call 911.
And I guess, yes, if deceased, call 911. But this is what's called the level of consciousness. So it's alert and oriented times 4. So we look at these 4 things. Does someone know their name? Do they know where they are? Do they know the time, which is asking the day or the month? Sometimes I don't know the day, so the month works. Or you can come up with something, what year is it? Also, if they don't know the day or the month. Who the president is always a pretty good one. Most people know that one. Pretty much everybody knows that one. And so those are how you can tell if somebody is alert and oriented times 4. If they're not alert and oriented times 4, then after a head trauma, then we want to have some type of intervention. If someone is intoxicated, so they are drinking and they have a head injury, they are at a much higher risk for a brain bleed or any type of head trauma that is more severe. In that case, what we recommend is that the person absolutely needs to go to the ER and have what's called a CT scan of their head to make sure they are okay. This is because they will bleed more when they're intoxicated because alcohol thins your blood. If someone is going to decline medical services, you want to make sure that they are signing the medical declination form. Or you guys have that form, correct? Okay. This one is really important, okay? If someone is drinking and they have a head trauma, we want them to go to the ER and have a CAT scan, CT scan. Typically, in this case, when we send them, I will call the ER directly, and this is any of our support staff can do this. Usually I'll ask to talk to the social worker because there's usually a social worker, if not the social worker, the charge nurse, right? Because the social worker is like our right hand in a sense. They're our ally, or the charge nurse. You can say, hey, this person's intoxicated. They had a head injury. We recommend that they have a CT scan to make sure that they're okay. And they're absolutely okay to come back to us when they're done. Okay? Why am I not? There we go. Okay, seizure activity. Have you guys had any seizures yet up at Kensington?
Yes, we've had quite a few, actually.
Okay, so let's talk about it. What do you do when there's a seizure?
Roll them over to their right.
To their side, yeah, so they don't bite their tongue or choke.
Open their airway and roll them over to, I believe, the left or the right. Oh, I forgot.
Okay, let's talk about it. So someone is having a seizure. First thing you do is you say to someone else,
Call 911.
Call 911.
call 911. Then you want to protect the person. So that's kind of what you guys were just talking about, right? So now this is like some of the old school techniques, Jack, what you were just talking about. But let's talk about what the recommendations are now. So you want to keep the person from falling if you can. So if they're on their bed and they're having a seizure, we're going to figure out how to glide them down from their bed, right? So you protect their head as you're bringing them down to the ground. Or if you can stand on one side of the bed and have somebody else stand on one side of the bed by giving them space, but making sure that they're not going to fall, that can also happen. You want to move furniture or other objects that might injure the person during the seizure. So again, if they're on the bed, they could fall off. So we want to try to get them to the ground if we can, and then push the other beds, if there's anything that's near them, off to the side. If they're having the seizure and it's on the ground when you arrive, try to position the person on his or her side so that fluid can leak out of their mouth. But do not apply too much pressure on the body. And this is like when we talk about log rolling, right? So we put one hand kind of on a hip, one hand on their back shoulder, and we can log roll them onto a side. And then we can put their legs, so their legs become like a tripod, and one of their arms becomes like a tripod. If you can do that. During this whole time, we have to remember the person is having a seizure and shaking, and it can be a really scary, intense moment. So if you're not comfortable doing that, you don't have to. Just clear the area around them. So you said clear their mouth, right, Jack? Okay. That used to be something that was recommended, but not anymore. Because what happens if you go to clear someone's mouth that's having a seizure?
Yeah, they can
They'll
get
bite
you,
down on you.
get your fingers,
Yeah, you may
or
lose,
bite their tongue.
you may lose a finger. And we don't want you to lose a finger in this. Putting something in the person's mouth can also cause injuries to them because it can chip their teeth, fracture their jaw, or you could get bitten. And we don't want to try to hold down the person or move them. That's why I said if you can ease them to the ground, ease them to the ground. But if it requires like really moving them, let the seizure happen, protect the area that they're in. Okay. There's different kinds of seizures. I'm not going to go over what all those are because that's way more than what any of us need to remember. But there's the convulsive kind, the ones that we're talking about just now. They are shaking. They're not really conscious through this. They're moving around. You want to cushion their head. If they've got glasses on or anything like that, move them out of the way, but keep those glasses safe because they're going to need them. If they've got some type of tight clothing, so again, like this is like a necktie or shirt up against their neck, you want to loosen that. Put them on their side, again, using the log roll. So one hand on their hip, one hand on their like shoulder back area to roll them onto their side. Time the seizure. This is really important. Paramedics will want to know this. Don't put anything in their mouth. So if you show up and somebody is having a seizure, you may look at somebody and say, can you time this for me? Or time this for me, starting right now while you're dealing with the person. The other person that's witnessing it, call 911 for me. Tell them that someone is having a seizure. Give them our address. If you're by yourself, you're going to do all of these together to the best of your ability. And if you can't, then you can't. You get 911 on the phone. You get the area safe, then you call 911. Don't hold the person down. When the seizure ends, typically people are really confused. Really, really confused. So just know that it takes them a while to come out of it. Our agency policy for seizures is to call 911. If you are someone who's at home or lives with someone who has seizures or experiences that, that may not be the case. However, at our agency, we're going to call 911. There's other types of seizures where people may just kind of vanish, like their vision goes blank. They may chew a little or shake a little. They may just stare off. These are minor, like partial seizures. So that's another thing to be aware of. There's different types, but for the big ones that we're talking about, you want to clear the area. So for the smaller seizures, if you recognize that something is happening with somebody, they could be sitting in your office and you're talking to them and all of a sudden they just stare off blankly. They may have a little twitch, a little shake. They may look around like they're looking at something. Ask them if they're okay. They may not respond. Stay with them. You can say to them, are you having a seizure? And they may be able to shake their head yes or no. Just stay with them, tell them that they're safe, and track the time on it. And stay calm because you're the one that's the calm one right now while they're having the seizure. Okay, any questions about those? Okay, allergies. So allergic reactions, right? Lots of people have allergic reactions, and those can be from mild to severe. So can someone read the mild reaction for me?
I'll go.
Hives. Oh,
Sorry, go ahead, Liz.
that's okay. Go ahead. No, okay. Hives, especially over the neck and face, itching, nasal congestion, rashes, watery red eyes. And then for mild reaction, calm and reassure the person having the reaction, as anxiety can make symptoms worse. Do you want to read the other side or no?
Yes,
Yeah.
please.
Okay. Try to identify the allergen and have the person avoid further contact with it. If the allergic reaction is from a bee sting, scrape the stinger off the skin with something, such as a fingernail, a credit card. Do not use tweezers. Squeezing the stinger will release more venom. If the person develops an itchy rash, apply cool compresses and an over-the-counter hydrocortisone cream. Watch the person for signs of increasing distress. Get medical help for a mild reaction. A health care provider may recommend over-the-counter medications.
Right, so something like Benadryl or something like that. And this is, so we can't, we don't give our clients medications at all. If a client has an allergy, like a small thing, this is what I'm gonna say. If somebody shows up and they have a rash, you wanna let your supervisor know, because we wanna look at, is this some type of an allergic rash? Because say they use new detergent, or they ate a food and it causes hives on them, or is this something like scabies, right? So you don't necessarily need to make independent decisions about this one. If someone's got a rash or an allergic reaction, I would run these ones through your supervisor also, so you can kind of talk it through and then they can investigate further. And you can recommend to the client, like if someone's comes to you and they're like, I got stung by a bee, your first question is going to be, do you know if you're allergic? No, I'm not allergic. Okay, then they're good, right? We want to make sure. Benadryl is obviously like a great thing. We can say, you know, have you ever taken anything like Benadryl when you have an allergy? Or do you have a provider that you see for the allergies that you have? Because what if they're seasonal allergies and it's, you know, right now it's springtime, so allergies are showing up everywhere. So watery red eyes will be, and nasal congestion are going to be around again because things are starting to bloom. When they get to moderate and severe, that's a little bit different. So can somebody read this one for me?
Yeah, they'll have abdominal pain, abnormal high-pitched breathing, sounds, anxiety, chest discomfort or tightness, cough, diarrhea, difficulty breathing, difficulty swallowing, dizziness or lightheadedness, flushing or redness of the face, nausea or vomiting, palpitation, swelling of the face, eyes or tongue, unconsciousness, and wheezing.
What do you think we do if someone's having that type of reaction?
Call 911.
If someone is having any difficulty breathing, automatically we're going to call 911, right? Airway breathing, circulation. So if someone is having wheezing, and this isn't like their normal wheezing, right? So because we have clients who are heavy smokers, so they wheeze normally, or somebody with COPD who will always struggle to breathe, but it's worse or it's different, right? You guys know your clients. If someone expresses any kind of chest discomfort, this is going to be an automatic for me, 911. And even if that chest discomfort is related to anxiety, better safe, right? Better safe by calling 911. And my job at this agency is to decrease utilization and decrease 911. So, and I'm saying, when in doubt, we're going to always call 911, right? Because we want to make sure that our clients are safe. We want to make sure that we're taking care of them, and we want to make sure that we're feeling safe in the actions that we're doing, okay? So with severe allergic reaction, who can read this one? It's a little bit longer.
I'll read it. Severe allergic reaction. For severe allergic reaction, anaphylaxis, check the person's airway, breathing, and circulation, the ABCs of basic life support. A warning sign of dangerous throat swelling is a very hoarse or whispered voice, a coarse sound, or coarse sounds when the person is breathing in air. If necessary, CPR and rescue breathing if trained. Call 911. Calm and reassure the person. If the allergic reaction is from a bee sting, scrape the stinger off with something firm, such as a fingernail or plastic credit card. Do not use tweezers. Squeezing the stinger will release more venom. If the person has emergency allergy medication on hand, help the person or inject the medication. Avoid oral medication if the person is having difficulty breathing. Take steps to prevent shock. Have the person lie flat, raise the person's feet about 12 inches, and cover him or her with a coat or blanket. Do not place the person in this position if a head, neck, back, or leg injury is suspected or if it causes discomfort.
Thank you. So this is the one that gets much more severe, right? So there are some people, do you guys have anybody who has an EpiPen with them that you know of? Yes. And so I don't know if you guys keep medications locked up for people. Some people, they want to keep their medication stored. Anyone who comes in with an EpiPen, 100% they need to have it on them, and staff should know where they're keeping it. If they're keeping it in their pocket with them at all times, or their backpack, or if they're keeping it in their locker. Okay, because if they're keeping it in their locker, which we have many clients who have been known to do this, and they've got a lock on their locker, and they eat the food that they're allergic to, and we can't access that EpiPen because we have to go look up their locker code, there's a problem. Right? Do you guys know how long, what the response time is for calling 911? The estimated time it takes for them to get to you.
Oh, it can be anywhere from 1 to 2 minutes to 10 to 15 minutes, depending on what's all going on around. We do have a couple of fire departments nearby for the paramedics to get here quickly, but I'd say on average, it's between 2 to 15 minutes.
2 minutes, an allergic reaction, where someone's having a severe allergic reaction, great. 15 minutes, not a great response time. So it sounds like you have a station that's like right next to you if you get the 1 to 2 minute response sometimes.
Yeah.
That's great. And they will hear what the call is for. And if they hear that it is chest pain, someone's not conscious or not breathing, they will get to you fast. They hear those calls when they're coming in. Yeah.
Quick question. I'm just curious on why it says to cover them with a coat or blanket.
You know, it's to prevent shock. Because their bodies go into shock, and when you're covering them, so depending on if their body temperature is decreasing.
So even if it's not outside, because of the severeness, they might start to feel cold.
Yeah, their whole body may start to shut down.
Okay.
So you gotta keep them warm. It's kind of like, even like if you're going into surgery or something like that, they have those things called the bear huggers.
Yeah.
They're warming blankets now to keep your body from getting too cold.
Yeah. Okay.
So like in a seizure or something like that, you wouldn't be using a blanket because you want to keep the area clear and everything away. And if you are covering someone with a blanket in a severe allergic reaction, you again just want to make sure you're staying away from their mouth and their face. Okay. And then anytime anyone has like a rash, or if they're like, my face feels a little swollen. Anytime someone says to me, my face feels a little swollen, or my tongue feels swollen and the back of my throat is itchy, I want Benadryl in them now. Because anything that is close to the airway, and this is our clients, you, your family, someone says, my tongue feels like it's swelling. I am going to say, as long as somebody can take Benadryl, right? Because some people have allergies to Benadryl. I would take Benadryl if I was feeling like my tongue was starting to swell. And then I would get myself wherever I needed to get. That is a very scary thing when someone's tongue starts to swell. Again, I'm not expecting you to give medication to anybody. You cannot dispense medication to anybody. So if somebody has something like that with them, it's a question. Hey, do you have any Benadryl with you? Is it something that you can take? If not, you're gonna call a medical provider for guidance. Okay, so that's it with those. Okay, and I want to open it up to questions, scenarios that you guys have had that you want to talk through. I know Michelle brought up a case that you guys have right now.
I'll go ahead and I'll start with that one. We'll call her Ty for now. But she has a wound that's needing a lot of wound care. She's been in and out of the hospital. For a while, they had her on IV antibiotics in there so that she could make sure she got them. And they give her really strong pain meds, like Dilaudid to take the pills form, and Norco, that kind of stuff. So it seems like they're alternating what they give her. Each time it's a little bit different, and then they'll tell her to stop the morphine and take the Dilaudid instead or whatever. So we've kind of been helping her to monitor when she's been willing. She'll let us hold the meds, and then she'll say, can I have a pain med? And we check the time and say, okay, it's only been 2 hours and it says to wait 4. Maybe you can take an ibuprofen in the meantime so she doesn't OD accidentally. But I think and correct me if I'm wrong, Leslie and Madi, is where it comes to helping her to clean the wound. How do we make sure, that we're not doing anything wrong? I know when I went to go purchase stuff for her, I was like, okay, I see the iodine, but I don't know if she's allergic to the iodine, so I'm not going to get the iodine. I was looking for a saline wash, but couldn't find a saline wash. So I found a wound care that looked like it had stuff that might be okay, just kind of help flush it out. What kind of, is it okay for us if she's cleaning and us to help hold the gauze for her? Where do we draw that line on that care? And how do we know when she needs emergency medical attention because the wound is that bad?
Okay, thank you for all of that. So Madi or Leslie, do you guys have anything to add?
No, I think what Michelle said is what we're dealing with right now, whether we're assisting her in cleaning the wound or not, or helping her bandage it up, or just in general, just being there, helping her, guiding her hands. We're not really sure what we're able to do or not in that case.
Okay, so I would say, first off, gloves. You guys need to make sure that you're wearing gloves. Anything that is saturated with her exudate that she has, if possible. I mean, Michelle and I can talk, but we should have some type of what's called a chuck, which is like a area that you lay down that's water resistant on the bottom, so that when she is cleaning things, she can put everything down there and then just wrap it all up really tight.
Okay.
And put it in a red bag if we have them. I don't know if you guys have that there. If it's a smaller piece of gauze, something like this, we can teach her to put it in the palm of her hand with the glove on, wrap her hand around, and then you pull the glove off, and then you put that glove inside the other glove and pull that off. It's called double gloving. So she should be wearing gloves when she's doing her dressing change also, or at least washing hands beforehand and washing hands after, but preferably with gloves, just so she's not introducing any infection. Absolutely helping her set up with what the supplies that she knows that she needs. So sterile gauze or regular gauze, probably sterile gauze, and then some regular gauze to cover it, rip off pieces of tape, however she's having it secured to her, and then sterile saline, right? And you can get all that stuff, Michelle, on Amazon. That's actually where I get most of my medical supplies. And then you can, I would say, assisting her with handing her what she's asking for, right? I wouldn't necessarily want staff who's non-medical and isn't trained in first aid to be gloved up and changing it for her, but guiding her and assisting her and providing that support to her, because it's probably a very scary experience to be going through. And even in the nursing field, there's a nursing diagnosis of altered body image, right? So she has this wound, it's on her chest, right? And then there's exudate, and there's stigma that comes with that, because other clients probably know and they can see it, and if she leaks and then sees it on her shirt. So really just being a support person for her and then guiding her through it. Things to look for if you are the one assisting her is additional redness, if there's any types of swelling, if the exudate changes in color, So if, say, it's clear or like a yellowish color now, but it changes to green or brownish, that's something you want to be aware of. The smell. So I'm sure for those of you who have been present with it, there is a smell. And if that smell changes to something that's much more sour or foul smelling, that would be an indicator that we want to make sure that she's getting more treatment. She does have a long history of IV antibiotics. I don't know if she's on antibiotics by mouth right now, and how often she's seeing her provider. But that's also something to like check on. How often is she seeing her provider? I mean, I'm sure you guys are kind of aware of that, but and maintaining her appointments.
That's been the biggest challenge. Not only is there the physical barrier, but there's also the mental health barrier, which is really extreme. And so now that we're at this point, fortunately for us, she's in the hospital and we're working very closely with the hospital, Marrisa. And so she's had some surgery to clean out the dead tissue. Now they're working on doing some additional surgery, but we have to check in every day. But we've shared with them that our staff is just not medically equipped to have the round the clock care for this client. So, you know, staff has done a phenomenal job in working with this client, especially with all the barriers. But our goal right now is if she were to return, what kind of support could we give her if they discharge her and she returns her? Because for us, I get it. It's like, we're not medically equipped, but if not us, who else is going to do it? And so we're in a position where, you know, we're doing the best we can. And that's why I said staff has just done a phenomenal job with her and have just shown her so much care and support. And so that's been a plus for us. But we're just, again, crossing our fingers, hoping that the hospital will keep her and she'll get transferred to a hospital where she can get additional support.
Yeah, and I hear there's a lot of compassion for her, and it sounds like a lot of above and beyond.
Yeah,
which warms my heart because it's
yes, it's so sad. It's not like I don't even want to say that, but she's so very young. She's so very young and so frail, and we've just watched her deteriorate, and it is heartbreaking. But that's why I say staff has just shown how much they care about our community. And I'm just really, really, really proud of how they have carried themselves to care for her.
Thank you for that. There's also, you can work with the hospital if they don't have a way to transfer her, because if she doesn't meet the criteria for a skilled need to go into a SNF, even if just temporarily, there's a Palmdale recoup. Right?
So what we're working on now is I've reached out. I actually submitted a referral to DHS.
Right. Perfect.
And they reached back out to me. They actually said that they have an ALW, which is assisted living, which is paid for by the state. So that's another avenue for us, but we're just waiting to see what the update is from the hospital if they're going to do the additional surgery. But yeah, we're ready to be able to assist her. We're trying every single avenue to make sure, because like we shared, this is not the environment for her to heal or just even go through this process. And so we're working to find other options, but we are aware that if there's nothing else, she would be here.
Yeah, great. I was going to say that's kind of one of the things we've done, like the pushback to the hospitals. We're like, you need to find an actual appropriate medical placement for her. And, you know, there's times where we've said to the hospital, like, you need to do this. And then when they've discharged them anyways, we go and get them. Or we'll work with the social workers at the hospital. I mean, I'm glad that the assisted living waiver program exists and that you know about it.
Yeah.
Because it is a really great option. If that doesn't pan out or doesn't pan out fast enough, usually through the hospitals, it can happen a little bit faster. So that's good that that she's in the hospital and they're willing to work on that too. Is again, just even like 2 weeks or a month in the recoup in Palmdale would be, you know, something where she would be getting daily medical care before she comes back to you. So that's
correct. I think they were experiencing some barriers because they were like, at first there had to be a reason why she needed the recoup. So now it's basically she would need wound care and IV care.
Yeah.
So that's what they're hoping to see if they can get something connected. But again, there's that other option of her having that additional surgery. There's so many different moving parts with this right now. And so it's just these different options that we have, but we're hoping that she can get some additional surgery done to be able to give her some more time.
Thank you. Does anybody else have any questions or anything before we go? I just want to be conscious of the time because it is 5:30.
I do have a question, but hopefully it can be very quick. I have a client. He has COPD, stuff like that, mobility issues, and then recently was diagnosed with diabetes. So I connected him with a nursing service that will come. The nurses can only come 2 times out of the week. He needs his insulin a couple times a day. The first nurse came, she said she couldn't give him the insulin because of, okay, never mind. That's my question. Your face already answered it. That's all I wanted to know.
It's probably whatever level of nurse that she is and what her license will allow and whether she believes in the order that's present. My experience with on-site nurses in our facilities, they come one time and then they may never come back again and still be charging. There are a couple nursing agencies that are not like that I've experienced as well. There's a lot of stigma with our population also. I don't know why he would need that support though, unless he's got some like visual problems or some learning.
No, he's afraid of needles. He doesn't like needles, so he can't administer it himself. And, you know, I just wanted to make sure what she was kind of telling me was true because it didn't sound right that she couldn't give him his insulin. And then another nurse, it took 2 weeks, but another nurse finally showed up and she gave him the insulin and he was fine.
One was maybe not an RN or an LVN, and the other one was maybe like a support staff. Or she didn't have the order.
Could be. I don't know. But I just wanted to make sure because I want to advocate for him with their company to make sure that he's getting the care that he deserves. And I didn't know if that was.
So I wonder if the pen, instead of like an insulin vial.
It's already in a vial, like in a needle, ready to go. They're already,
He's got like a pen or it's in a syringe.
It's in a syringe, but they're all individually ready to go already. It's not like he has to get it out of
the nurse like set it all up for him.
No, that's how they came. They came like full of syringes that were already filled.
Okay, and he just dials in how many units he wants and then puts.
Yep.
So those are the pens. So, I mean, there really has to be a lot of working with him on his fear of needles and like what the long-term effects of diabetes are to get him like through whatever fear he has. So the pens, the needle tip on those is so tiny. And if you're doing it in your abdomen, right, you rotate the spots around like in a circle, you cannot even feel those ones.
Okay.
But so I think that's a lot of the teaching right now with him is really talking to him about what his fear of needles are. And then also like kind of educating him on what the long-term effects of untreated diabetes is.
Okay.
Because he's got to get past that.
The diabetes, does that cause swelling?
It's the COPD is probably what's causing his swelling.
That's what I'm thinking. I think he has fluid on his body.
Yeah, he probably needs to be on a diuretic to help get the fluid off of his lungs and then his body. If he's swelling more than normal, he needs to be seen by his provider.
Well, yeah, he was at the doctor, and when he went in, it was so bad they kept him for about 2 weeks. They got all the fluid off. He was back up and walking and moving, and he was able to breathe a lot better. And then, like I said, I set up the nurses. They didn't come for 2 or 3 weeks, and now it's getting right back to the same point.
He's not taking his pills, it sounds like, either.
I know he's not taking the diabetes medicine, but I think maybe some of them, I've seen him take his pills before. I'm not sure how regular he is with it. Yeah. But I have seen him take it. I know he knows to take it. I know he's
it sounds like he's probably not taking them regularly. What can be really helpful for clients like that is if you get the med cassettes, the pill box.
That we're gonna do too. Yep.
And so we can't, as non-medical staff, you can't take the pills and put them in there, but you can work with them and sit down with them and like make the med cassette every week with them, which is also really good because then it empowers them and it teaches them.
Yeah. So we were talking about that with the nurse. The nurse is actually, she's also an in-home support specialist. So she said she can do his in-home care for him, which would mean she'd be able to come every day and administer, you know, medication, set up his medicine box and all that stuff. So that's what we're hoping for to happen next.
Yeah, poor guy.
Yeah. Yeah.
Yeah,
So,
because he just gets worse until he can't breathe because he's got too much fluid on his lungs.
exactly. And that's why I wanted to ask those questions and see if it was the diabetes. Is it because he's not taking the insulin? You know, and just trying to see what other support that we can provide for him.
Yeah. Lots of conversations with him about that fear of the needle.
Okay. Will do.
Yeah. Any other last minute questions, comments?
I have a quick question. So, I know like this is a lot of information, so like obviously not everybody knows this information. Do you have by any chance like any like posters that we can be posting in like the offices so that way other staff are aware? Because not everyone can take the training or has, you know, but just something like that's quick so that way if one of these were to happen, we can easily just look there.
So I can, Carrie, we can send out the PowerPoint and you guys can like have a little like what to look for book where it's got each of the things. I think I have all of it on like just a Word document also, which is maybe just like 3 pages that I can send to Carrie also and she can get out to you guys. And then this is recorded so that people who weren't able to be here can watch it.
Thank you.
And we're going to have another series of courses kind of like this where we'll look, it's going to be a 3-part series. It'll be coming out soon. It starts, I can't remember when it starts. But each series will have like 4 medical conditions that are talked about and then kind of the red flags, what to look for, what you can do, like education and prevention. That we're going to have some nursing students actually creating that training. So, and those will be recorded also. So we're gonna, this is the first of more that we can provide this support to you guys.
Great, thanks.
Yeah, thank you. It's good to see all of you. Nice to meet you.